Hey all, Eric Christensen from the Real Life Pharmacology podcast. I am a big podcast listener. I like learning different things and just stumbled across a podcast that fits right in my wheelhouse, and I'm guessing it'll fit in yours as well. You got to check out the Mechanism of Action podcast. It reviews a lot of history about where medications came from and were derived. It's really going to help your understanding of medications and also be a little bit entertaining as well. So go check that out. Highly recommend it. Mechanism of Action podcast. Hey everyone, welcome back to the Real Life Pharmacology podcast. Today I'm going to continue on my theme of gastrointestinal medications, and I am going to cover antacids. And more specifically, I'm going to cover those short-acting antacids. Some people would consider H2 blockers and PPIs antacids, and technically they are. I've covered those in previous episodes, so go dig into those a little deeper if you want. On here, I'm going to talk more so about calcium carbonate and some of the other antacids that are commonly used for acute relief of heartburn and indigestion and things like that. Before I do, I want to make sure that you guys remember to look at medication lists. There are numerous medications that can cause chest discomfort, heartburn, stomach upset type symptoms that many patients may try to mask those side effects by using an antacid. So just going to run you through some of the major ones that I see on a chronic basis, cause some issues and kind of may lead to the prescribing cascade. So first, NSAIDs, notorious cause of GI upset, heartburn type symptoms. Obviously can lead to more severe things like stomach ulcers or gastric ulcers as well. Ibuprofen, naproxen, diclofenac, there's lots of NSAID examples, so make sure you catch that if a patient's reporting new GI symptoms. Obviously aspirin, even low dose can sometimes cause it in some patients. If patients are using it for analgesic purposes, they might be using higher dosages, and then it's obviously more likely in that setting or situation as well. Corticosteroids, big one that I've seen cause some issues. Oral corticosteroids like a prednisone burst, for example. Pay attention to that. Seen numerous cases where we start prednisone and, within a few days, 3 days, 5 days, a week, and now the patient is, popping Tums or calcium carbonate to help, alleviate the adverse effects of some stomach upset and heartburn-like symptoms. Bisphosphonates. So typically those, once a week, once a month oral agents that we give for osteoporosis, they can definitely cause some esophageal irritation, mimic some of the signs and symptoms of heartburn. Potassium chloride. Oral tablets, capsules, they can, again, cause some esophageal and gastric irritation. Iron supplements occasionally can cause some gastric upset and symptoms like that. We do have some antibiotics, oral antibiotics, doxycycline, tetracycline, clindamycin. Those are probably the most notorious for causing esophageal irritation and mimicking symptoms of GERD. Probably less common, but occasionally opioids you may see cause some delayed gastric emptying as well as increasing, those reflux type symptoms. GLP-1 agonists, typically we think more so in the realm of nausea with these, but, possibility for some reflux type action there as well. Digoxin, specifically more common in toxicity, but should be aware that digoxin can cause some stomach upset and dyspepsia there. And last common medication I'll mention here is metformin. This can definitely cause some GI upset and indigestion type symptoms. All right, so don't forget about looking at that med list and those medications I went through. Now let's get into antacids a little bit deeper. So antacids are what's called weak base type medication, and essentially they neutralize hydrochloric acid in the stomach. And that neutralization of that stomach acid, or of that acid, it's going to provide a rapid onset of action. These medications are going to work generally pretty quickly, oftentimes within 5 to 15 minutes. They are pretty effective for occasional heartburn. They're inexpensive, they're over the counter, and you will absolutely see patients utilize this in your practice for sure. Now, some of the challenges with these medications in general, they work quickly, which is great, but they generally don't last very long. So if a patient has kind of chronic symptoms all throughout the day, we generally don't want to keep having to pop these medications all day long. And I'll explain to you the reasons why as we increase the dose and dosing frequency, some of the challenges we may incur there. These are generally not considered effective for healing erosive esophagitis. So again, we're basically just treating some symptoms here, and again, less useful in chronic GERD compared with those stronger, more potent acid suppressive therapy with H2 blockers and PPIs. All right, let's get into some specifics. So calcium carbonate, in practice, this is the most common antacid that I see used. Common brand names of this are Tums, Rolaids, you'll see advertised maybe occasionally on TV as well. I do want you to keep in mind that some of these common brand names, they can have different ingredients in them. So you've really got to do your due diligence and make sure you look at the back of the label and see what ingredients are actually in there, because sometimes that does vary between different brands and things like that. So again, pay attention to that. All right, so calcium carbonate, you're going to get, that acid neutralization. You're going to get rapid symptom relief. It can provide, obviously, some supplemental calcium. The most common patient population that might benefit from that is generally postmenopausal women who may have bone loss or maybe at risk for osteoporosis. Adverse effect profile. I'll talk about drug interactions coming up later on and some of the binding issues that can happen here. From an adverse effect standpoint, constipation can happen with the calcium carbonate type product. And if calcium carbonate is used in excess, we can actually cause hypercalcemia. And I've actually seen a case of this where a patient had a significantly high calcium level because they were popping Tums all day, and it was actually combined with hydrochlorothiazide, which can also raise calcium levels a little bit as well. So that's why we got to be really, really careful about using these in excess. Using one once a week, probably not a big deal. You're probably not going to get excessive, calcium in the bloodstream. But if patients are taking them chronically, taking a lot all throughout the day, that risk goes up with the more and more of these that we take. The other thing I'll mention is kidney stones with calcium carbonate, particularly patients that have had an issue with that in the past. So as we take more calcium, the calcium in the urine will rise, and if that urine becomes what's called supersaturated with calcium or calcium salts, that calcium can be more likely to bind with oxalate and phosphate, and we can begin to form crystals or, obviously renal stones. So pay attention to that in some patients that may be at a little bit more risk for that concern. All right, next one is magnesium hydroxide. Milcomag or Malox, those are common brand names here. Again, rapid onset and probably the big advantage over calcium is if you do have a patient that struggles with constipation already. The magnesium component tends to be more on the diarrhea side. So, if you've got a patient that's, reporting some constipation already, magnesium hydroxide may be a little bit more appropriate for sporadic use for the relief of heartburn and indigestion. So adverse effects, as you could expect, diarrhea. We can get to the point where we're getting too much, and we cause more diarrhea than constipation with the magnesium component. And we can also, again, similar to calcium, we can cause excessively high magnesium levels. And this is particularly true in patients with severe renal disease. And we can check magnesium levels, and that is something that I've certainly recommended in my practice when I see patients taking a lot of milk of magnesia, for example. Okay? So again, pay attention to those patients with CKD. That magnesium can absolutely accumulate. Aluminum hydroxide, you may find this in combination in some Maalox type products. Again, similar to the others, it neutralizes that stomach acid, and it is often combined in many products with magnesium to balance out the bowel effects. So aluminum is the opposite of magnesium. It's similar to calcium, and that is probably going to cause more constipation than it does diarrhea. Now, remember that aluminum hydroxide can be used as a phosphate binder in patients with significant renal disease. Okay? So if we remember that, we can understand that a potential side effect is, if we're using this frequently, we can bind up all the phosphorus in that gut, and we can cause low phosphorus levels. Okay? So can be a problem. Again, not very common if it's sporadic use of aluminum hydroxide, but if you've got a patient that's maybe overusing or abusing it, that can be a potential concern with aluminum hydroxide. In addition to the lowering of phosphate levels, we can have accumulation of aluminum. Okay? And long-term aluminum toxicity is not a good thing, obviously. And that can certainly be a lot more concerning in patients on dialysis or with significant or severe renal impairment. The risk for aluminum toxicity is something I have seen come up on board exams, again, particularly in relation to that renal function issue. Speaking of board exams, if you're looking for content, BCPS, NAPLEX, geriatrics exam, BCMTMS, we've got tons of content. Thousands of pharmacists have used our content, and it's helped them prepare for and pass their board exams. It can absolutely help you too. So again, if you enjoy this podcast, go support the sponsor, meded101.com/store. Got a great list of resources there. If you're a nursing student, pharmacy student, med student, tons of books, tons of resources, tons of review courses. Again, go check all those out at meded101.com/store and help support this podcast. All right, so last one I want to mention is sodium bicarbonate. Common brand you might hear with this is Alka-Seltzer. Again, look at what is on the back of the label. There's a million Alka-Seltzer combinations in different products, so make sure you understand what you're getting. Advantage of this medication is it does provide some very rapid symptom relief, like many of the others. Some of the concerns with it, obviously more so if we're frequently using it, we can have that high sodium content. So we can cause excessive increases in sodium levels. Okay, so pay attention to that in excessive intake. Now, the other place, other than just higher sodium in the blood, the other place of concern is in hypertension and heart failure. Okay, so high sodium intake can potentially worsen these conditions, and so sodium bicarbonate might not be a great choice for acute relief of indigestion and heartburn in a patient who has heart failure, for example. Okay, so again, very, very important to pay attention to that. There may be a little bit more burping and belching from a little bit of carbon dioxide production with the use of this medication. Metabolic alkalosis has been reported as well. Again, usually that's higher dosages and excessive use, but again, something that you should pay attention to and inquiring how frequently you're using the medication can help you decipher how seriously you should be concerned about that. All right, finishing up drug interactions, got to touch on this a little bit. Super, super important, particularly with calcium and magnesium and some of the binding things that can happen with this medication. Levothyroxine, iron, tetracyclines like doxycycline, quinolone antibiotics like ciprofloxacin, levofloxacin. These are medications that can be bound up by calcium and by other antacid type products. So what that means is if you give let's say calcium carbonate at the exact same time you give ciprofloxacin, that calcium carbonate is going to bind up that cipro, okay? And that means that the ciprofloxacin can't be absorbed as well as we would like it to. And so you end up with lower concentrations of ciprofloxacin, and that's going to potentially lead to antibiotic treatment failure if you're treating an infection. And so super, super important to pay attention to that. Ask about antacid use, ask about calcium supplement use and things of that nature. Those binding interactions are really, really common, and I don't see them get caught a lot. Patients don't get educated on them, and I even see that quite a bit in assisted living and long-term care, where nurses administering the medications or the provider prescribing it, they don't recognize that they're taking a calcium supplement, for example, in the morning and evening, or they don't recognize that they're taking Tums. And then we have those binding interactions, and we wonder why the patient didn't get over their infection and the antibiotic didn't work. So super, super important to pay attention to that. That is one thing in practice I've seen a ton. One last thing I will mention, calcium carbonate is something you see somewhat common in pregnancy. Obviously, we want to be careful with how frequently it's used. But heartburn and indigestion certainly can happen in pregnancy, and so calcium carbonate is generally one of kind of the go-to agents to use sporadically to help with those symptoms. So something, a little nugget there to pay attention to that definitely might show up on a board exam. All right, well, that's going to wrap up the podcast for today. Hopefully you picked up a few practice pearls. If you did, do me a huge favor. Share the podcast with others. Leave a rating review on iTunes or whatever platform you're listening on. I greatly appreciate that. And of course, email me, mededucation101@gmail.com. If you've got any questions on study materials and books and other resources, I can certainly guide you in the right direction there, as well as take any feedback on the podcast that you might have as well. With that said, I'm going to sign off. Thanks so much for listening. Take care and have a great rest of your day.